welcome to this webinar on process mining in health, and thank you very much for joining us. I'm Mike Anderson. I'm the Technical Standards Lead at the Faculty of the BCS at the BCS Faculty of Health and Care, and my co-chair this evening is Tito Castillo, who is the Strategy and Policy Lead at the Faculty of Health and Care at the BCS. And our speaker today, as you probably all know, is Owen Johnson from Leeds University. We're going to be recording this session if you haven't already seen that, and the recording will be made available on the BCS website in due course, as indeed will the slides. The way it's going to work is that Owen's going to talk for about 40 minutes, and then we'll do about 10 or 15 minutes of Q&A. The way we do this normally is for people to put their questions into the Q&A or into the chat. We seem to have both working at the moment, so we'll try the Q&A as the preference, but if that doesn't work, please put any questions or comments you have into the chat. Tito and I will keep an eye on those as you're making those comments and questions, and then we'll go through the most high-profile ones at the end and have a Q&A. So I think we're probably ready to go. Owen, over to you. I'll allow you to introduce yourself and take it away. Thank you very much.
Thanks, Mike. So what on earth is process mining? Well, I'm guessing you've read enough about it to have clicked on the links and signed up for this. So I'm kind of hoping that you've got a little bit of interest in what process mining is, and I'll talk about that. And given that this is the BCS Faculty of Health and Care, I'm assuming that you are someone in or related to computing, and that you're someone who's interested in or working in health and care. So I hope that's a fair assumption. I'm looking forward to the discussion at the end, because I'm really kind of keen to hear from yourselves as to what might be useful, what kind of take homes, and what your thoughts are. So just as a quick intro then, my name's Owen Johnson. I'm an associate professor at the University of Leeds in the School of Computer Science. I've worked in digital health on and off for nigh on 20, possibly 25 years, definitely 20. It's hard, it's a blur. And in the last 5 years, I've been working in AI, but for the last 15 years, I've been working in process mining. And so what I want to do is I'll talk about process mining, but also want to talk about how AI fits into healthcare. That's not the main subject of my talk, but what I want to do is show you how process mining can help with AI projects and help shape the way we might use AI within the NHS. So I hope that's kind of relevant. So those of you that work in data will recognize a lot of what I'm going to say, but I also hope that this is reasonably accessible to anyone who's kind of just working in the healthcare area and interested in or involved in digital health. So I hope that's useful. I should say I also run a Masters by Research program, which I run for what was NHS England, still is at the moment. And so a lot of these examples are from the NHS and from either national or local examples. So the strap line that you saw when you clicked on the link was an introduction to process mining in health, how it can help drive innovation in care, lower costs and improve patient outcomes. That's the sweet spot for all of us, I think, is innovation, cut costs and improve outcomes, and also probably treat people faster, I guess. I think process mining as a tool set is a very valuable way that the NHS can achieve that sweet spot. So I've got a little chance of half an hour or 35 minutes to just try and convince you of that. And if we start with the pressure the NHS is under, including in AI, process mining, I'll introduce, I'll talk about the fact that the NHS has got lots of data. And really where I want to get to is to demonstrate with some examples how process mining can be used to improve NHS care pathways. And then I'll kind of finish with something called the ClearPath method, which was developed at the University of Leeds as a methodology for process mining in healthcare. And at that point, I'll leave you with links. And if you're interested, you can dig deeper or contact me, and I'd be delighted to talk you through how to take this further. So I was going to start here. This is our former graduate from the University of Leeds who's done quite well for himself, and is now Prime Minister. On 13th of January, he talks about the government plan for AI. So it's called the AI Opportunities Action Plan. Launch there, you can watch the YouTube video. The quote to me that I think resonated most interestingly is this, the one in this Guardian article here. He wants to mainline AI into the veins of the public sector. So those of you working in AI or working in the public sector, just get your head around this. You know, it's going to be mainlined into your veins. So the AI action plan, which I've put links in here, and the slides will be available, so you can click on these later. Investment in AI, rapidly pilot and scale AI, using the public sector as the exemplar for the private sector, which is kind of interesting. He gave a lot of examples in healthcare in his speech. So we might want to think about how the government's agenda over the next few years is going to very much depend on adoption of AI to make the savings that they have started to promise. In particular, he talks about the UK as an AI maker, not an AI taker. And this is kind of interesting. You can't really see this very well, probably, but this is one of the figures that, or bits of information that Keir Starmer quoted. It's Stanford University's AI report, which puts the United Kingdom as third for global vibrancy of AI after the USA and China. So much as we might be pessimistic about our country, the fact that we're a very small country and we're third globally in AI is something that we should see as an opportunity. And I can't talk about AI too much, but I think it poses the question, what are we going to do? All of us working in the computing and in healthcare kind of really need to think about our plan for the next couple of years. Now, I did this slide before the NHS England announcements. So there is a kind of rethinking about how we reorganize healthcare, and appreciate that there's a lot of people doing a lot of thinking in that space right now. I haven't got answers for that, but I do think that I want to leave you with the conclusion that data is going to be essential to AI. AI, as we can see from this slide, is essential to the government strategy. So those of us working in digital health who produce data which will inform AI, we must have jobs. They need us. They cannot do this without us. So I want to kind of roadmap a little bit about how we can be involved in delivering what the government are hoping to achieve. Okay,
Just before you, sorry,
sorry,
just before you move on, one or two people have put their hands up, but we can't handle that at the moment. If you could just put any questions or concerns you've got at the moment either into the Q&A or the chat, and then we can look at them later. But we'd like to let Owen talk through to the end first, if that's okay with everybody.
And this is very much a put your hand up slide, isn't it? So let's come back. Let's have this discussion because it's a very interesting discussion. Let's have this at the end. Give me a chance to kind of get to my end point, and then absolutely. Let's come back to that. Thanks, Mike. So you never ask an academic what he does, because then you'll get at least 40 minutes research lecture. I'm trying to cut this down to a few slides just to explain what I do. So I run something called the Electronic Healthcare Records Research Group, part of the School of Computer Science, but also strong links into medicine. And so what I've been doing over the last 15 years is working across a whole range of different medical domains, using a whole range of different data science, process science techniques to, at the top right-hand corner, to just get some insights into care pathways. You know, humble aspiration. Can we just see what a care pathway looks like, and can we make it better? So that's the humble aspiration, top right. More ambitious and maybe aspirational is the idea of a learning health system. A learning health system is where we use data, we learn about the healthcare system, we implement changes in the healthcare system because we've learned from the data, and then we evaluate what we've done with the data. So we create a learning loop where the systems, the data, and plans for improvement are on a continuous learning cycle. So that's the utopian dream. And the humble aspiration for the meantime is just care pathway insights. So I'm trying to get somewhere between those two. So let me talk about the government's agenda first, because you could sort of see it summarized from this sort of like nice simple slide. Huge public rollout of AI, in particular the waiting lists. How do we tackle waiting lists? We want to move to this glossy, colorful future where everything is beautiful and happens wonderfully for the patient. So there's a kind of current and future aspiration, and I want to focus on that for the purpose of this talk, because the secret magic beans that we want to throw into this is a black box AI, and just somehow throw that in and hope that that leads to this wonderful future. So I run an AI Medical. It's a centre for AI in medicine. I owe £8 million. We have 50 PhD students working in the space. As an AI developer, I'm thinking immediately, well, what AI are you talking about? And obviously ChatGPT has taken the public imagination, but that's not the right type of AI. That's a chatbot. That's what we need is diagnostics that are going to spot cancer cells. We need stuff that's going to do predictive analytics based on your GP record, that's going to say, well, actually, you need to have some cardiovascular tests. So we need much more practical AI. So I would like to know what AI, where it's developed, and how was it trained. And in particular with AI, a lot of the work that I do is around risk and bias. So if you train AI on white middle-class males, that's not necessarily going to work for the rest of the population. So we need to understand AI, when it works, when it doesn't work, and its risks. So that's my view as a developer. But as a clinical person or as a healthcare service manager, the question they ought to be asking is not what AI, but where. Where do I put the AI? Early diagnosis, making machines make decisions faster, robot process automation. So exactly where would the AI go in the business processes that the NHS does is a much more important question. And that's the implementation challenge that I think I want to spend some time talking on, and I want to try and give you some potential solutions too. We still come back to the same questions about the real world implications and users and risks and biases as well. So let's focus on that current to future switch. And the technique that I want to show you is how we can use something called process mining to analyze the current as is pathway, what's happening now, before we move to some kind of pathway improvement process and design the future or will be pathway. So I tend to talk in this as in, will be, and sometimes I talk about the designed pathway, and I'll kind of explain that. But you can see a pathway as a process map, and if you've never seen process maps before, don't worry, I'll show you some, and we'll talk about how those are created. So the title of the talk then is process mining. Process mining as a phrase has been around since 2005, and it was coined by Will van der Elst, who's known as the godfather of process mining. Will wrote the first ever book about this. You can see the picture in the top left here. I was lucky enough to see Will on Thursday, so this is actually Thursday in London. And so I've spent, as an academic, I've spent a lot of time working in this academic sphere, developing the academic frameworks of process mining. But really important message, I think, for everyone is that process mining is absolutely huge in Europe. Not so in the UK and in the USA. So I've been going to process mining conferences for 10 years, and I've frequently been the only English person there. And also hardly any Americans, possibly one every second year. However, the largest supplier of process mining tools has 5,000 employees and is worth $13 billion. It's a huge industry outside of healthcare and outside of the UK. So part of my job is to evangelize and just talk about what the rest of the world is doing, and how it can maybe help the UK and UK healthcare. So first thing to say about process mining, there is a simple technique, and I'll show you that technique. But before that, say that it's a body of knowledge that includes everything that you know about data science and probably a load of stuff that you may not heard of about process science. So you might have heard of business process improvement. Some of you will be good at benefits management, benefits realization. You might have formal methods, workflow, operations management. So there's a world of process improvement. And there's also a world of data science. Process mining is this bridge that links the two together. So I'll give some examples of the breadth of process mining, but also I will teach you how to do simple process mining as well. So me kind of just starters on the simple view on any process is that you've got some inputs. You do a process and you have some outputs, and behind that you've got some feedback, which is data, and control, which might be management, or it could be AI, I guess, in the future. So typically when pathways are designed, they're designed as though they're straight lines. You know, start here, go through here, go through here, go through here. Have we finished? Yes, good, done. So we have it's like a conceptual framework of designed pathways, and I just want to just spend a little bit of time thinking about the difference between those design processes and what reality is like. So this is a thought experiment. If you're paying attention, sit back. I want you to look at this pathway and imagine yourself walking down this pathway. And we can't do a show of hands, I'm afraid, but you're welcome in your own house to put your hand up if you think you would follow the wibbly wobbly route and wobble round each of these lovely paths. So you imagine you're walking along here, around here, around here, around here, around here, around here, wibble, wobble, wobble, wobble. Possibly, I mean, for me, I would do this the first time, just for fun. Probably by about second or third time, I'd be knocking off some of these corners. And certainly if I had to do this walk every day of my life, I'm just going to go straight across here. So here's an example of a post-implementation as is pathway. And you can see the design, why the design was flawed. In this case, it's taking you close to loads of wet bushes, and it's the longer way round. You can see that we're probably trying to get you away from the road. So you can see why the design is this, but you can also see that nobody's paying any attention, apart from this guy. Well done. What we've got here are traces. These are footprints footprints on the ground that are giving us a clue as to what the reality is. And I think of process mining as the same thing. It's where let's look at the traces that tell us what's really happening, and compare that to the design. So I'll show you how to do this in the electronic format. But if you've got this mental image of it's a pathway, it's designed, people aren't necessarily going to follow it, and we can see the evidence of the fact that people are not following it. So, okay, so so I've given you that simple model of a pathway, input, process, output. This is reality. It's chaos. We have an NHS that manages to deliver amazing care despite the managers coming up with simple pathways, not because of them. We have very, very experienced people that know what they're doing, complex patients who also know what they're doing, and some people that maybe don't know what they're doing, and somehow we manage that chaos. So the as-is pathway is a bit more challenging. So if I put the as-is pathway next to maybe what a designed pathway might be, you might see, well, this looks like chaos. This looks like it's utopia. How do we close the gap between the reality and the design? Well, if you zoom in a little bit just here, in that screen there, you'll see screens, computer screens. This is great. This is a hospital using digital health. They've got computers and they're typing into those computers information about patients. So we have evidence that patients are being treated, and it might be that they're admitted to the ward, they've had some drugs, they've had some care, they've had a diagnosis, they've had some further treatment, maybe gone away for some surgery, come back. All of that data could, or at least should, be in our electronic healthcare records, which means it should be in a database. So those databases are our traces in the grass. A database is the records of what the as-is pathway actually was. And process mining is to look at this data and use it. So if I come back to my simple model, and I kind of thread that with this complexity idea, in simple models, we have input, process, output, feedback, and control. Reality is healthcare organizations are hugely, hugely complicated systems. And they're made up of subsystems that are also hugely complicated, all the way down to an individual ward, which is also very complicated. So the bit that, if Wes Streeting's online, well, hopefully he's not, Mike, bump him off if he's here. The bit that we shouldn't say out loud is that money going in doesn't necessarily lead to better outcomes coming out. It's a non-linear relationship between inputs and outputs. So that does mean that you can improve the processes to get better outputs without putting more money in, which is why I don't want Wes on the call for this bit, but because I don't want to give him ideas. But on the other hand, this does mean that we are, if we can get our heads around the fact that healthcare is incredibly complex, doesn't mean that we can't solve it, and it doesn't mean that we can't make it better. We just can't fix it forever. We can. So I'm going to talk about 4 methods that I use in my research: process mining, process simulation, process improvement, and process modeling. I will primarily for this talk focus on process mining because that's the title of the talk. But I'll try and make some links to the other 3, just to, maybe it's another session on another day, and if you guys invite me back sometime. So I'm going to focus on process mining. Process mining is like the feedback bit. It's looking at the data and understanding how did that work, how did that pathway work to get the kind of control that we might need. So this is a bit where I dive in, and I'm going to try and teach you process mining in 2 or 3 slides. That's it. And then if it works, great. So let's take that starting point of the healthcare system that's got electronic healthcare records. We're gathering data about patients. That patient data is going into some kind of relational database. To do process mining, what I do is I look for anything with a timestamp. So any case, the case might be a patient, it might be a hospital admission, any activities that take place that have got a timestamp, and I select those event logs, a list of activities that relate to an individual patient or case, and I collect those, and then there are a range of tools, which I'll show you in a minute, that will allow you to produce a care pathway model. Those of you that are familiar with process modeling will recognize this as a BPMN model, business process modeling notation. Some of you might use UML for process modeling. They're pretty similar, so I wouldn't worry about the difference. And also process mining does something like this, much simpler, directly follows graph, which I'll also show you. So I think I can teach you process mining in, I don't know, what's the time? Let's go for that. How about 1 minute? Let's see if I can do it in 1 minute. I know, Mike, if you've got a second timer, let's set the scene first. Don't start timing me yet. Okay, what we're looking at is a spreadsheet. Those of you that worked in this field might realize that's accident and emergency. These are unique patients, 1 to 10. Each patient's got an age and a gender, age and sex. They have got an arrival date, assessment time, clinician seen. Some of them go to specialty, some come back, some are referred. Not all of them have a bed request, etc. So you can see that sometimes we've got date timestamp, sometimes we've got blanks. So this is the kind of typical data that you might extract from a hospital system. So, okay, ready? Now we can time it. I'll see if I get a stopwatch on this. Okay, if I was trying to process mine this, I would label each of the things, each of the columns that's got a time. And in this case, an A, B, C, D, E, F, G, H, I. So there we are. Now, if I look at the first patient, I can see that the trace of the first patient is that they do A, B, C, D, but not E. They do F, G, H, and I. If I look at the trace of the second patient, I can see that it was just slightly different. Trace of the third patient is slightly different again. So if I run through each of the lines, each of the traces through each of the patients, I can write down the sequence. So if I drew that out on a piece of paper, I might spread out all the different activities like this, and then with a pen, I could start drawing out the traces. And visually, you can start to see, well, they all do ABC. And you might say, well, I wonder how many do each of the traces. So you could simply do some very simple analysis, which says, well, which is the most frequent set of traces through. In this case, a third of them do this A, B, C, F, G, H, I. And 2 of them do something slightly different. All the rest of them are unique. So imagine we take that for the whole of accident and emergency department. I can quite usefully see the main flow of treatment. I can see most of the other typical types of treatment, and I can see the unique cases. And really what process mining is just does this with powerful tools. So a tool set to do this is basically how process mining works. So I'll give you some examples, but I think that was, I don't know if that was a minute, Mike, but it felt like a minute. You're muted. But, okay, right. So hopefully you've learned process mining.
It was an NHS minute.
Oh, okay. Well, there was a waiting list just before. Okay, good. So you learned process mining in 1 minute or a little on or off. So if I just expand that out a little bit, we typically will start with relational databases which have got some kind of entity relationship diagram. You can't really read this, but just take my word for it that the red bits are date timestamps. So anything red with a date timestamp is potentially interesting to mine. So there's obviously a range of SQL to suck data out and to put it into this format, which is, you know, possibly a spreadsheet, but or a CSV, and it's event log with these activities and times. There is a tremendous amount of work processing this kind of event log, but the end result is you push it into tools and you can get these most frequent traces, unusual traces, and this lovely diagram, which is what's called a directly follows graph, where the darker colors and the thicker lines are the most frequent paths. There's a variety of tools, and I'll give you a list of those at the end. So if you're happy that that process is something that if you can't do it, I'm sure you can find someone to do it. You can produce nice little graphs of what the current process is. So I'll give you works example. We did this with NHS England last year. We worked with East Midlands ambulance data for best part of 1 year's worth of data. Those of you that have been unfortunate enough to be in an ambulance, or more likely just seen an ambulance, the process of ringing an ambulance we all think of as quite linear. You phone, you talk to a call center, they will organize an ambulance, the ambulance will pick you up, take you to hospital and hand you over. So that ought to be a linear pathway. So we took NHS Midlands ambulance data, fed it into a process mining tool and got this. This is what we would call spaghetti. It's a technical term. It's a technical term meaning a whole right old mess. And this is typically what we find whenever we do process mining, particularly in NHS data, we get massive amounts of spaghetti. It took 2 months of work to kind of massage this, talking to domain experts to work out what was real, what was imagined, what was data quality issues, how do we kind of make sense of this and narrow it down. So what we managed to do that. This is work by Alex Coles, who's one of my PhD students, but he was on secondment to NHSE at the time. So Alex boiled this down to the blue boxes and the thicker lines of the default pathway for an ambulance. There are a few other events that happen, but he's kind of narrowed it down to the basic flow. And what Alex was able to do was then he worked out each of the different types of outcome for this pathway in terms of whether they were referred to primary care or transferred on to somewhere else or discharged. And he's set each of these outcomes as a destination for the pathway. And then he was able to use machine learning to do the prediction of, based on what's happened for this type of patient, what do we think would be the outcome? So he used process mining, then he fed that into a machine learning algorithm, and then he found that it did kind of discovery of what features were most important, found that the initial clinical category of the call accounted for about 30% of the importance in the prediction, which basically is the person that you're speaking to on the phone when you ring 999, and reassuring that, you know, around about a third of the time, if you like, they're getting it pretty accurate in terms of assessing the right people to put in the ambulance to send to you. But other reasons are there as well. So I won't bore you with the rest of it. But what I hope you've seen then is the process of process mining, the ability to create process maps, and then the ability to start doing some cool stuff with prediction and machine learning and AI to see how we might improve that pathway. So there's some warnings, and I'm going to talk about the warnings next. So this is an exercise we did, that spreadsheet that I showed you with the accident emergency. Those 10 patient records, I should have said, they are not real patients. That's synthetic data I typed in for this talk. However, that format of the spreadsheet we did get from Leeds Hospital and we did use for this exercise. So if you are based in Leeds, this is useful information. In the days when there was a 4-hour wait, the median time that people waited, which is this J curve here, the median time that people waited in Leeds A&E was 3.9. And those of you that are veterans at this game will know that that's because everyone is gaming the key performance indicator. And I'm not saying they're actually waiting until close to 4 hours before they treat you, but certainly if it gets close to 4 hours, they run around and treat you because they don't want to breach. Worryingly, if you're after 4 hours, this grey zone is not promising. So if you're a breach, arguably you might as well go out and come back in again. It might increase your chances of being seen. Sorry, I'm just joking. I hope that's taken as a light joke. Okay. Oh, let's hope so. Yeah. So what we did do though was we looked at things like the pathway through A&E, which during the daytime was quite linear. During the nighttime was much more chaotic in the way that things happen. So, for example, people had a bed request before they'd been seen by the clinician. Doesn't quite make sense. We were able to narrow this down to 6 p.m. and explain why at 6 p.m. the A&E pathway went haywire. And you may, if you've worked in this world, you may know it's the shift change. It's the night shift arriving. They clear the decks. And so if you are waiting in Leeds A&E, I would go at 4 p.m. so that when they're clearing the decks at 6 p.m., you're out fast and you'll have achieved a 2-hour treatment. We were able to surface this. So this is what we call discovery. We're able to drill down and examine the pathways. And we sat down with the A&E manager and said, well, look, we can tell that this is happening. Is this what you want? And we had some very good discussions about the process improvement. But at that point, that's the A&E manager's job and the clinician's job. Our job, if you like, is just to tell them what we found. So, so I think that says to me, when you're doing process mining, you need to work with the domain experts who are the people on the ground, clinicians and service managers. So just to sort of give you a taste of the kind of work we're doing, we're looking at, in research world, we're looking at predictions of, as you go through the process, predicting bad things. The bad things might be these red boxes, like readmitted within 30 days would be a good example of something you would rather avoid. So if we can work through as patients are passing through our pathway, can we predict that? And we've done some reasonably positive work which suggests that we can predict patient outcomes as they're in the pathway and do some positive things to improve that. The other kind of work we've been doing is to take process models and feed them into proposed simulations. So this is a simulator rather than a real pathway. And in this simulation of the care pathway, we've added cost. So we've added cost for each of the different activities. And in this case, the little circles that you're seeing here are patients traveling along effectively a road network, looping around, going backwards and forwards, and eventually getting to one or more good outcomes. So what we've done with process simulation is to be able to sort of say, what if I add this extra diagnostic test here that improves the accuracy of later steps in the pathway? Can I improve outcomes and also reduce costs, which is that sweet spot that the government would like to hear. And I can't say, yes, this works, or no, this doesn't work. But what I can say is, here is a method for you to find out. Here is a method for you to experiment with what if scenarios based on evidence and real data, as opposed to hypothetical arguments. So the work I'm doing at the moment is to take real life data through IT systems and data into event logs, and do process mining through to this kind of stuff that you've seen. But I'm also, and part of my research group is to look at a link through to process simulation for these what if analysis. And we're kind of trying to thread the whole thing together with synthetic patient data as a kind of glue, so that we can do this lovely round tripping. And that round tripping is what we could use to do learning health systems. I hesitate the phrase, the digital. Some people would call this a digital twin, but I think there's a swear box for that word. Sorry. Okay, so I have written a paper which you're welcome to access and download. We can distribute this, at least the link to it, in the chat. I developed a method called ClearPath, which is based on the industry standard PM squared method for process mining. And PM squared was itself based on something called CRISP-DM, which some of the data miners will recognize as a de facto well-known data mining process. So this is very much in the data mining world. And in the ClearPath method, probably the biggest single take-home, I would say, is work with it's this top right-hand corner. Get a clinical reference group of domain experts who can advise you on what you've done and whether they think it's useful. So second piece of advice is do this in iterations. So join the two bits of advice together. And the way I've done these projects successfully is to book all my domain experts once a month in advance for the whole project. And then I can go away with my team and build stuff, show it to the domain experts, understand whether that was data quality or process improvement or whatever, and then get my homework, go away for a month, come back, meet them again. And just iteratively mine and discuss as a loop. And at some point, after probably 3 or 4 iterations, you'll have got some really good breakthroughs. So the ClearPath method is there for you to read and look at. What I would say, which is the NHS is challenging environment, but care pathways follow typical patterns. So wherever you are in the NHS and wherever you're working, you will see things like triage. So it is a kind of very typical pattern. You'll see referrals, you'll see sub-processes and parallel processes, straight lines and cycles. So as you start to spot repeatable patterns, you can start to sort of become quite adept at process mining. And you process mine, you spot a pattern, you think, okay, that's a triage. There is a concern about waiting lists, and the waiting lists typically happen between these handovers in the steps in a path pipeline. So if we're trying to focus on how do we reduce waiting lists, map the path pipeline, map the pathway, the waiting list will drop out, and then we can look for improvements at each of these steps. And typically those improvements will be based on something called theory of constraints, which is that any pathway, any process is limited by one weakest link. If you fix the one weakest link, it gets better. But of course, there's another weakest link. And there's always another weakest link. So, but you can at least get a stepwise improvement each time you identify the weakest link, fix it, and then move on. So the theory of constraints is a kind of nice, simple, pragmatic way of dealing with this kind of waiting list type problem. And there's a lot of work on this already. There's well-known, this is the Our House statement. There's well-known models of patterns in care pathways, which I've just put these slides in so that you can, if you're interested in this type of space, there's already work done that you can build on. The two things that we've done with colleagues, I work internationally, and we've produced something called the Process Mining in Healthcare Manifesto, where we've looked at the characteristics and challenges of healthcare data as specific, as different from every other industry. So I won't run you through all of this, but we've done quite a bit of work looking at what's unusual in healthcare. If you've worked in this space for a long time, you'll read this and smile, because you'll know this. Those of you that are newer to this might read this in horror, but it's important that you're aware quite how challenging healthcare data is. And we've made some recommendations about things like start from real world problems and use standard terminology and get a holistic process view. So this again is in the paper that you can have access to and read and think about if this is something that's of interest to you. If it's not, what I want to do is summarize just to wrap up. This is where the government's at right now. They want huge public rollout of AI. They want the glossy future that we all as patients want as well. We want to get rid of waiting lists. We want decent, fantastic healthcare and a great NHS. Throwing AI in needs thought. It's not magic beans. You can't just drop it in. We need to be careful with how we do it. And that's where I come back to this. There is a development challenge, but all of us, I think, should be thinking about the implementation challenge. And to my mind, process mining is the way to do your before and after. So I'm leaving with this strap line, no AI without process mining. And then I thought, well, now I better qualify that a bit. So I put comma, please at the end. So comma, please, no AI without process mining. I think, Mike, I've kind of done, I've got, this is a slide that's for anyone who's interested, with a list of links to the commercial software tools and the free tools. I'm running some, if you people follow me on LinkedIn, I'm running some process mining courses in Leeds as well. So, but there's good online courses as well. So, and I think that, I'm hoping that was it. I'm kind of, I don't know, I saw hands go up. So if that's okay, should I stop sharing? Is that okay, or do you want to? Should I leave these up? Or
Well, you might leave your links up just in case people want to.
Yeah, okay. I'll leave those up if people want to try them. So just for those people that are programmers, there's an R library called boopart and a Python library called PM4Py. So if you do want to dive in, then okay, right. So that's me done.
Excellent. That was very, very good indeed. Thank you very much, Owen. Very inspiring, very interesting. And I didn't need to use AI to mine your process. It was perfectly timed. So that's excellent. And unsurprisingly, you've generated quite a lot of questions and comments in the chat, which I hope Tito is going to help me go through so that we can pull out the priority ones. But one that came up fairly early, and after that, I'll hand over to you, Tito, because I can't read all the rest, is this is from Loy Lobo, isn't process mining reliant on events being recorded when they take place? What if clinicians are recording events at the end of their shift?
Good grief. Yes. Thank you. Yeah, absolutely. I didn't say on that slide of Leeds Hospital A&E, there was exactly that problem. We were suspiciously finding that a lot of bed requests were made at 4 a.m. in the morning, all at the same time. And that's exactly that problem. With data mining, you can only mine what's there. And the reality is there's a lot of activity going on that doesn't get typed into the electronic healthcare record system, or if it does get typed in, it's typed in after the event. So the date timestamps could well be wrong. You're absolutely right. And my methodology for dealing with that is to spend a lot of time doing what you might say is plain old boring business process analysis. So my projects, I actually go and sit in the clinical environment as well. Watch it, talk to clinicians, get them to explain what they are doing and what they aren't doing. And when you get the data, be incredibly suspicious, always. So typically when I've produced process maps, the first iteration is horribly, horribly wrong. Second iteration is a bit wrong. Third iteration is a bit right. And the fourth iteration is getting there. And there will be gaps in what's recorded and what's not recorded, and you can try and use inference to fill in the gaps. But you're right. There is maybe a kind of ideal ideological argument that if clinicians aren't typing it in, they should be made to type it in. But you know, those of us who are older know that's not going to happen.
Well, I think that's dangerous territory, isn't it?
Yeah, exactly. Yeah, exactly. Hopefully that's a good answer, but you're right.
Right. Okay. I'll hand over to Tito to pick out some of the other questions to answer. Of course, some of them are quite long, and I haven't been able to read them.
Okay, so so Leon Lindsay, I don't know if you can come on to talk to your question. You asked the question, how do you feel about starting with functional requirements, then go on to make quite a detailed statement. So it'd probably be helpful if you're able to.
Hello, can you hear me?
Yes, we can.
Yeah.
Hi, that's good. Hi. Hi, nice to meet you all. So what would you like me to say? Shall I just quickly, I've asked a question and I can expand on the point. So I'm a CCIO for Northeast and North Cumbria ICB for AI. And I'm also on the BS 30440 panel. One of my main observations is that AI should not be an end in itself, or any methodology shouldn't be an end in itself. We have to consider our functional requirements first of all. And this has been one of the problems with the transition to paperless. It's often slower than paper because we don't consider the redundancy, the extra steps, and inefficient interactions. So mining is undoubtedly helpful in identifying constraints. And I was very keen to hear you say theory of constraints is really a very accessible way of measuring our problems and focusing on the bottlenecks. So how does process mining fit into that? And how does it identify an inefficient interaction rather than just documenting it without diagnosing it, if you see what I mean? Can it be fixed?
Yeah, I mean it's so the answer I think is that it's a tool within a tool set which you need to use in combination with other tools. So what process mining will do is it will give you visibility on some aspects of the patient journey, but it will give it to you as hard data from your own databases, and in particular it will tell you the time gap between each of the events in a patient's journey. And so when we're looking for process improvement, we might spend some reasonable time just looking at the gaps between activities. The easy thing that it will do is it will spot what happens to what happens immediately before bad outcomes. So let's take something like the readmission within 30 days. Which we might see as a bad outcome. So it'll spot that, and it'll spot the data behind that, and help you understand what sequence of events might have led to that. In combination, though, you'd probably want to use some traditional data mining as well. But so process mining gives you that visual image. It gives you something to discuss. Data mining will give you maybe some more harder evidence on some aspects. But then my key thing, I think, is this clinical reference group. You do the process mining, you have a discussion. The discussion is probably the important bit. I don't know if that helps, Leon. Is that
does help. I'm just saying I think the priority should always be our functional requirements. So we have a long waiting time because of, let's say, extended consultation times. And that is correct. So we can document that and identify that through process mining, but we don't know it's actually poor HCI that's causing a lot of that. If we had optimal HCI, we could, in theory, double throughput with the correct application of AI, paperless technology, pathway management, and so on. So that's the sort of level I am really keen to analyze things at. It's quite simplistic, it's very explainable. And it's right, these are the points, these are the pinch points, we need to fix those. And we can mine all this data, but it won't necessarily point the finger at the problem.
Yeah, no, I agree. Yeah, I mean, it's going to give you clues to where the problems are. And you're going to have to use a whole range of techniques, including just common sense from the clinicians on the ground, I guess, as to where the problems are, and the management team. What you can do is there's a lot of work trying to get the data in a form where you can produce the as-is current model. Once you've done that, though, if you then implement some AI or any other kind of process improvement, if you've gone to the work of linking your data to a process model, you can just keep running that model. So let's say you've implemented AI 6 months ago, you can just run that process mining exercise again and see whether the AI has genuinely improved the pathway. So I think process mining as an evaluation tool post hoc is really very exciting as potential. So if that makes sense, as a kind of come back afterwards, or I mean, arguably real time, but you should be looking at the implementation of AI to say, has it actually worked?
Yes, I think that's the essential metrics, and this is certainly one of them. So thank you, and thanks for answering the question.
Oh, thanks. Yeah, that's good. Really good questions.
Thank you. Now we sort of have 3 data quality related questions. So I'm wondering whether if I pose you all 3, they sort of seem to go together.
Yeah.
So Sobath asks, given the challenges of incomplete or inaccurate data in traditional process mapping, how can integrated process mining with systems analysis enhance the effectiveness of clinical process reengineering? Then Sarah from Angus apparently asks, the challenge is obtaining accurate data from process mining without increasing the work for both hospitals and staff. We should not need to enter even more information onto our computer systems manually. How are we going to avoid that? And then finally, Basil points out that the data quality is the Achilles heel, and says, given that that is the case for all our efforts to understand the systems, do you have any thoughts on addressing the underlying data quality that reduces the burden and complexity of the analysis, so it doesn't need 2 months and multiple PhDs and is more efficient and responsive?
Good. Wow. God, crackingly good questions. Let me try and answer that with some really simple answers. Number one, I think, is use what you have. So don't try and capture additional data. If you use what you have, you should have the beginning and end of each patient's pathway. So they've been admitted and they've been discharged. So you should at least have the start and end part bits. What you've got in the middle of the patient's journey, well, in almost all hospitals, you'll have transfers between wards. So you will have the framework of a pathway recorded in your PAS systems and in your EHRs. And I take the point that they may well be recorded wrongly, and so you kind of don't necessarily know what to trust. But what you've got in between, pragmatically, I would use whatever you've got in between. There are typically in a patient record systems lots of things with date timestamps on. All of those are candidates that you might want to process mine, and really only a conversation with, as Leon said, what are the actual requirements, what you're trying to do. So you need to know what the objective is, which bits of data might be useful and relevant where. So I certainly wouldn't process mine everything. I would be selective, but definitely start with the beginning and end. In terms of what to do with the data quality issues that you identify, the really good solution, and it's a very horrible thing to say, but fix it at source. If you've got a systemic issue with the way data is recorded, then it's good to do root cause analysis to identify why that data is being recorded systemically wrongly, and try either tighten the user interface or training with the team or whatever. But if the data is wrong and that data has a patient safety issue because it's wrong on the patient's record, then you might want to sort of ask people, can we fix this, please? And it may be that people just didn't realize that there were patient safety issues with data quality. But generally, I would say I'd look at the individual patients. If their record is wrong, then does it affect their care? And if it does affect their care, then it shouldn't be happening. And so, that whatever anyone doing data mining on hospital data, a lot of people do fixes on secondary sources of data. I would go to the source and I would fix it for once and for all.
Okay.
I think I picked up. Did I pick up on everything on that? Yeah, just keep lots of bites of the cherry.
Well, I wanted to just ask a follow-up question related to this, and that was, what you felt the role of metadata is, because it feels to me that metadata management is relatively poorly served in the NHS. What could be done, by better metadata?
Yeah, I think I mean, wouldn't it be nice if we could compare the processes between wards in one hospital? Wouldn't it be nice if we compare one hospital with other hospitals? Wouldn't it be great if we could kind of look across the healthcare system and understand how the system hangs together, where we've got individual data models in individual proprietary applications all over the place. It's very hard to be able to do kind of statistical comparisons. So metadata, to my mind, is a way of understanding the overarching data structures so that we can just compare Birmingham with Leeds without having to kind of spend 6 months doing some kind of data mapping exercise.
Okay, thank you. I also wanted to, if it's possible, pull Sanjeev Gupta in, who's made quite a few comments, and I think it might be helpful to allow him to just pitch in.
Yeah, we need to be quick, but yes.
Are you available? Maybe he's not.
I am here. Sorry, can you hear me?
Yes, we can.
Yeah, hiya.
Hi there. Owen, that was very fascinating. Thank you for that. That was really helpful. I think there's a lot of that, a lot of what you teach there, what you've shown there could really help me in the teaching I'm giving to managers and future leaders in the NHS. So I've sent out a LinkedIn invite to you, wondering if we can connect. Thank you. But,
no, of course, yeah, and likewise, I think hopefully you're not alone. If other people feel the same, by all means, either my email address is at the beginning, and or LinkedIn is fine too.
Brilliant.
Yeah, absolutely. Yeah, I mean, the purpose of me doing this is because I want to have conversations with people, and I'm trying to reach out. I'm also plugged into the NHS Central team for process mining. There are 5 of them, and so that NHS process mining team, I was with them this morning. Some of them downstairs to me now.
Under Sonia Patel?
Sorry?
Is that the team that used to be reporting into Sonia Patel when she was at...
No, I think that's a different group.
Right, okay.
There's that group as well.
Yeah.
This is NHS England reporting into the Data Services Directorate currently.
Okay. Yeah, that's interesting.
But there's 5 of them, and they're looking to do case studies, and they're willing to get out there and help people. So anyone who contacts me, I can put them in touch with them as well.
Okay.
Thank you very much.
Thanks very much.
Is there anything else you wanted from me, Tito? Or
no, that's fine. Thanks.
And Mike's keen to move forward, aren't you, Mike?
Yes. Well, okay. So what we could do is that we could draw this to a formal close now, but if Owen doesn't mind, we could just chat for 5 minutes. If anybody wants to hang on informally for 5 minutes after we close it down, and then we'll have to close it off properly at 18:35. Is that all right, Owen?
Yeah, no, of course. Yeah, absolutely.
Yeah,
yeah.
okay.
So I'll stick around. If people need to go, then I'll say bye.
Yeah. Okay. So I'd just like to say many thanks again to Owen for what was an excellent talk. I hope that has started or increased the momentum towards getting more process mining done in healthcare in this country. As Owen said right at the beginning, we don't seem to be doing it much here, but it's being done a lot in other places. And from what I can see, it would be hugely beneficial to us if we did it more in the UK. So from that point of view, I thought it was very valuable, and I thought it was very instructive. So what we'll do now is we'll stop the recording.